Good afternoon, everybody. My name is Chris Maycock, and on behalf of the Peninsula Parkinson's Research Interest Group, or PENPRIG for short, I'd like to welcome you to our Sugar and Spice and All Things Nice question and answer webinar today. With me from PENPRIG are Sue Whipps and Nigel Coleman, and we're pleased to have Jane Rideout from the Parkinson's UK Excellence Network, whose support has enabled us to offer this webinar. The two principal members of the panel are Dr. Simon Stott, who's Director of Research for Cure Parkinson's, and we are expecting Dr. Laurie Mischley, who will introduce herself as when she arrives. I'm delighted that Simon and hopefully Laurie are in the same virtual room, and we are expecting some great questions from our audience. So without further ado, I'd like to hand the baton over to Sue, who has the first question.
So I'd like to ask, first of all, some people swear by the ketogenic diet, but how do the studies you outlined fit in with that, please?
Right. So the ketogenic diet has been around for a very long time, and it's based on this idea of ketosis. So most of the energy that our body uses in the Western world involves carbohydrates. We take in carbohydrates and we burn them up, and we use it as energy. A lot of it is coming from glucose, for example, so sugars. With ketosis or the ketone diet, you're instead of burning up sugars or carbohydrates, you're burning up fats. Your body starts burning fats, and the liver starts to make them into what's called ketones, and our body can use these ketones as a source of energy. So what do we know about ketosis and ketone diet in the context of Parkinson's? The answer is unfortunately not a lot. As with all of this research on diet, we simply don't know. There haven't been the really strictly controlled clinical trials looking at the ketone diet in the context of Parkinson's. There have been some small studies, and it's a difficult study to do because to make sure that people are in ketosis over the long term of the study is a difficult challenge. So yeah, unfortunately, I don't really have a solid answer for you, except that we need to see more research on it.
Sorry, I think that's going to be an answer to a lot of the questions here. I have another question from Pat. Why are Parkinson's people not tested for vitamin B6 levels?
Yes, so quite often you'll be diagnosed by a clinician or a neurologist, and they will say, go, part of the NICE procedure for diagnosis of Parkinson's involves going to a dietitian, but there's not a lot of follow through there, and so that's basically why a lot of people aren't. I mean, I'd be curious to stand at a supporters group and get a raise of hands of how many people have actually been to see a dietitian. I can't imagine very many, but it's certainly a recommended thing to do.
My husband had his B6 taken as part of a therapy drug trial. Mm-hmm. I don't know how we can run drug trials if nobody does a baseline vitamin level. Yeah. So this is a factor that's being addressed now with a lot of clinical trial design, doing sort of a very broad baseline measure as opposed to simply looking at motor symptoms, etc. Because the way our body metabolizes drugs or therapies can play a key role in whether that therapy is going to work or not in the intended way it's supposed to. So yeah, it's one of the weaknesses of clinical trials to date, and it's certainly being addressed. Thank you. And if I ask the next question, this is from Anne. In Dr. Stott's presentation, he stated that higher dietary intakes of vitamin B6 improve outcomes.
how much vitamins B6 should people with Parkinson's take?
So with a few of the vitamins, with actually a lot of the vitamins, we don't know what the maximum tolerated dose is. But in most cases, your body is pretty robustly designed to clear it or deal with it. My mother was always very, very big on multivitamins, and she was forcing these pills on the poor kids as we were growing up. And the vast majority of what was in that little pill was probably excreted away because your body can only handle so much of certain things. So off the top of my head, I don't know what the daily recommended dose for vitamin B6 is, but it should be easily found with a Google search online. But it's probably better to discuss these sorts of matters with your neurologist or your clinician or your GP before actually starting to play with the levels of it in your diet.
Thank you.
I have a question from Audrey. Dietitians know that, well, an observation from Audrey. Dietitians are not that knowledgeable in my experience. What do you think, Simon?
Well, if Laurie was here, I would refute that utterly and completely. The thing is, it's a very different discipline to clinicians, the medical doctors. They are encyclopedias of everything that we know about small molecules, diseases, and procedures to correct those diseases, etc. Dietitians come from a very different position, and they are experts in the nutritional value of what we're putting into our bodies. So when you go to them with a medical condition, I think it's a case of managing expectations. They're not going to know everything there is to know about your medical condition, but they will have a better handle on what you should be feeding your body than what the clinician who diagnosed you probably has. It's a rather delicate question to answer.
Thanks to Audrey.
Thank you, Audrey. Yes.
I have a question from Timothy Webster. Can you offer any research-based guidance on dosing of Theracumin and or curcumin formulations for PD?
Yeah. So there has been a clinical trial with Theracumin in California, where they took people with mild cognitive impairment, sort of very early Alzheimer's, and they gave them Theracumin. This is Theracumin, for those who are not familiar with it, is a nanoparticle formulation of curcumin, which is coming from turmeric. And it is because the problem with curcumin in general is that it's got very low bioavailability. That means it doesn't distribute into the body very well. So researchers have developed these nanoparticle formulations of it to enhance that bioavailability, to increase the amount and distribution of it in the body. And there was a clinical trial of Theracumin, this product, that showed improvements in people with mild cognitive impairment over I want to say 12-month period off the top of my head. And there have been other studies with the Theracumin that have also demonstrated beneficial effects. They're mild beneficial effects, I should add, but still they are beneficial effects. I cannot remember off the top. I'm probably as bad as one of these dietitians Audrey was referring to in terms of remembering daily dosage of things that I should have off the top of my head, but I can't remember exactly what the daily recommended dose of Theracumin is.
That's great. Thank you. Back to Jane.
Jane's obviously away with the keyboard at the moment. Could I ask on behalf of Hydron what you think of the intermittent fasting? That sounds like a big question to me.
Again, you're not going to appreciate the answer, but again, this is similar to the ketone diet situation. I've spoken with people online who have had very good responses to intermittent fasting. But these are anecdotal N of 1 sort of situations. But we haven't really seen carefully controlled clinical trials of looking at N of 1, at intermittent fasting as a therapeutic approach for PD, which is a shame.
At the risk of stealing the questions list for a minute, the question I have is really, should we be expecting clinical standards in this kind of situation? Because it is extremely difficult to control someone's diet, let alone their nutrition in the real world. And so I wonder if we need to learn to accept lower standards of evidence than the clinician is used to, in order to share more reliable information about these dietary additives.
Yeah, I would certainly agree with that. I'm not sure there is anything I'm not sure there's anything in a dietary intake that will have the same sort of impact as something like L-DOPA, which is immediate and dramatic response in most people with Parkinson's. There are, of course, sources of L-DOPA in your diet. There are lots of legumes, for example, that provide high levels of L-DOPA. So I'm going to be careful how I answer that. But when we talk about vitamins and other sort of factors, I'm not sure there is anything that has an immediate response like what we see with a lot of the small molecule pharmaceutical agents. Nothing I can think of off the top of my head.
I actually don't think many of our participants are looking for an immediate therapeutic response.
No.
They're looking for something which helps them in the long run manage their own Parkinson's.
Yes.
And it would seem that exercise and diet is a very good place to start.
Yes.
So I'm sorry I butted in there as well.
No, that's a very good point. Appreciate it.
Who's going to take that one?
Right, I'll read this. You mentioned free sugars increase glycation, but carbs like potatoes, rice, pasta, pastry, dried fruits, bananas, and many other fruits and tubers do too. Why don't we just put a continuous glucose monitor on your arm and track your individual response?
That would be a really interesting study to do. You can actually also get very small, sort of the size of a coin, little sticky plaster like monitors that you put on your arm for ketones as well. And they send you a message to your cell phone when you're in ketosis or out of ketosis. Alarms go off. And similarly for glucose, with regards to diabetes, for example. Quite a large portion of the Parkinson's community are not diabetic, but they certainly have trouble with their glucose levels. So it would be a very interesting experiment to do, just to monitor over time.
There's certainly more evidence about an association with diabetes and Parkinson's. So this is Audrey again. Do you think we should have a test for insulin resistance when we're diagnosed with Parkinson's?
Probably it would be certainly very useful. I'm sure some clinicians do go down that path, but with the results that have been had in clinical trials with diabetic medications such as Exenatide, the GLP-1 agonists, it could be that the responders in those studies are they're not diabetic and they're not having issues in terms of being sort of early diabetes, but it could be that there is some other factors at play in some of the people who respond. Again, we're looking at this in the phase 3 study at the moment. That's ongoing at the moment.
Yeah, because Exenatide is coming in, and I don't know the action that uses. Maybe you do.
It's what's called a GLP-1 agonist, and which is a small little receptor, and it helps people with the way that they manage their insulin levels. And in the brain, it's also been shown to impact neuroprotective mechanisms. So, but it's also been shown to boost levels of dopamine. So what we could be seeing with Exenatide, some of these beneficial effects that we're seeing with Exenatide could be that there might be a combination of neuroprotective, disease-modifying effect, and also symptomatic response in terms of raising levels of dopamine. But as I say, this is all being investigated in the current phase 3 trial.
I've got about 4 questions, haven't I, in chat? The first one is the ketogenic diet actually counterindicated? Because you said, the jury's out. But I have seen papers where it's recommended for people with Parkinson's, and I've seen papers where they say don't take it. So,
yeah.
Are there really risks?
We simply don't know. I've seen papers that say the same thing: benefits and also caution. We simply don't know is the answer to the question. We simply haven't done enough studies to weed out who might be responding and might not be responding. As I say, anecdotally, I've talked with a few people who have had great responses. I've also spoken with people who haven't had no response. So
Great response and no response is great. Nobody's had bad response then.
Well, yeah, there could be a response fallacy there, in that the bad responders don't contact me. But I think, it's the safest answer is simply that we don't know. Sorry.
Okay. Can I ask another one, Jane?
Please.
I read in Julia Enders, the lady who wrote the gut book, about red meat, and what she was saying was these studies were done in America, where red meat means cows that are hormone injected and injected with antibiotics, and really you shouldn't eat them. But European cows, generally grass-fed, not overcrowded, so eating red meat from where we live is very different from eating red meat from the States. So I just wondered what whether the jury was out, and whether there's been studies comparing USA red meat and European red meat.
So regardless of where the meat comes from, if Laurie Mischley was here today, she would tell you that you should eat less red meat. She has done large experiments, and I should apologize here now, right at this moment, because I misquoted her study in my video. I said it was a small study. It was actually a very big study. It was 1,000 people.
Yep.
And red meat was one of the sort of dietary factors that was associated with worsening of progression. So anything in a can, sugars, etc., and red meat also. We should cut back on our red meat, just in general, I think. Give the cows a break.
Okay, I'll be quiet now.
No, please. If you've got other questions, fire away.
Vitamin B6 and vitamin B12, I've been taking them for probably 18 months.
Yep.
Supervised. I can't get a GP appointment, that's true. And I have a friend who's a nutritionist who said B12 and B6 are probably low. If I ask for a blood test, I'm seen as one of the worried well, no? So
As one of the worried well, sorry? That's a new phrase
worried
for me.
well are people who are actually basically well, but they're anxious about their health. And it seemed like a trivial. I saw Sue nodding. We're seen as too fussy. there's other more important things to do than measure your
Well, speaking as one of the worried well, I don't care what they think. I want the blood test results. Is my attitude. I'm afraid it's fairly straightforward. And having been involved in various conversations over 10 years, I've lost patience with those who see me, who choose to see me in that way. It's my blood test result. I need it. And my wife, who is not afflicted as I am, has the same attitude. You need that information. And if you have to bully people to get it, I'm afraid that's what we have to do.
Okay.
I would just reiterate that your body can only handle so much vitamin B12 and B6. So as long as you're sort of supplementing, you should be doing okay. It varies from individual to individual. We each process these things in different ways, but if you do have low levels and you're supplementing, you should be fine.
I have a question from Elaine. What is the best way to deal with constipation and the problems of affecting the effectiveness of medication?
I would err on the side of caution here and refer you to your clinician. Constipation can be affected by lots of different things, and I don't think I should comment on that one. I'm afraid. Sorry. Okay. I wish I could, but I won't.
Probably. Thank you.
Is there any known correlation between falls in hemoglobin levels and Parkinson's disease? And can medication for Parkinson's compromise absorption of hemoglobin from food? Is the same true for vitamin B12? My husband, who was diagnosed 10 years ago, is having injections of vitamin B12, but the GP is also concerned that he's undergone a significant drop in hemoglobin and is mentioning the possibility of an iron infusion in hospital. So if we take that little bit first, is that okay?
Yes. I have absolutely no idea about the falls in hemoglobin and Parkinson's. There is definitely a large portion of the Parkinson's community that are low in vitamin B12.
And vitamin B12 is part of the hemoglobin metabolism, isn't it?
Yes.
Well, not part of it, but facilitates it.
Yes. One thing I will say about the vitamin B12, there have been studies where they've looked at vitamin B12 levels at baseline and then measured it several years later. And what they have found is that those who had low levels at baseline are more progressive in their Parkinson's, and will have lower levels at the end. Those individuals are more progressive in their Parkinson's. Those who have low levels of vitamin B12 at the start of the study and then higher levels at the end of the study are not as slow as those individuals who had low levels and they got lower. I didn't really explain that very well, sorry. But hopefully you get the idea. But generally, low levels of B12 are associated with poorer prognosis in terms of Parkinson's. So supplementing B12 is not a bad thing to do.
Yeah, I know people who've had colonoscopies and all sorts of hemoglobin tests, and nobody has thought to do a B12. No GP has done a B12, so I find that rather confusing.
Elaine said she really wanted to know if there's an awareness of the problems of constipation and the take-up of medication. I think that's why the question about constipation just now is more about is there awareness of that rather than actually what's the answer, just so you know.
Their constipation is one of the most common non-motor symptoms of Parkinson's. It can affect up to 70 to 80% of the Parkinson's population. So that's a well-recognized symptom of the condition. Clinicians can usually help as well with things like laxatives, etc.
Yeah, and there's a question from Jane, which I don't know whether you might be willing to answer. Perhaps Sue, you'd like to read it out. Jane Ollier?
Yes, I've always had a sweet tooth, but with Parkinson's, it has gone into overdrive. I do try hard not to indulge. And are there any ways to reduce cravings?
So I had a slide on the presentation that dealt with this exercise and social interactions and these sorts of things. Natural sources of sugar can also help. So eating fruits, sweet fruits, oranges and things like this. You can also go in the opposite direction and have some salted or peanuts or something like that. That can often help with cravings. But if Laurie was here, she might be concerned about me giving dietary advice like that. But yeah, it's really, really tricky. I have a sweet tooth myself, and I have absolutely no self-control.
Can I just say also that these cravings can come with dopamine agonists and binging on sugars. So I think if you are getting that, rather than be strict with yourself, just check your drug regime and to see if agonists might be the problem.
Yeah, that's a good point.
Question from Hazel. Drug repurposing. Is there anything on the horizon to help with PD?
Yeah, so organizations like ourselves, Cure Parkinson's, we run a large clinical trial program which started out as a drug repurposing situation. And we have numerous clinical trials ongoing at the moment. A phase 3 clinical trial for a drug called Ambroxol will be announced very shortly. We're just in the final stages of preparing that. And that's a respiratory medication, so it helps with mucus in the chest and the throat. It's widely used in Europe, but one of the interesting aspects of Ambroxol is that it also raises levels of an enzyme that's involved in the waste disposal system of cells. And there are people who have issued very low levels of this enzyme in Parkinson's, and we want to know if by boosting that enzyme, can we increase the waste disposal in cells, make the cells healthier and give them a fighting chance of survival? Will that actually slow down the progression of Parkinson's? So that study will be hopefully getting started before the end of the year, but as I say, it's just dotting the I's and crossing the T's at the moment. And then there are other clinical trials being set up for several others. And we should have the results of the UDCA study coming out very soon. UDCA is a medication that's used in the breaking down of gallstones. And what researchers in Sheffield University here in the UK, Dr. Oliver Bandman is the lead investigator. They've found that UDCA enhances the function of mitochondria in cells. And they've been doing a clinical trial called the UP study, looking at the safety of UDCA in people with Parkinson's. And yeah, the results of that should be coming out very shortly. So there's quite a lot of clinical trial results and clinical trial activity ongoing at the moment.
What are the top 3 nutraceuticals that Parkinson's patients should consider based on currently available research? And I think that last question might be the trick.
Well, they're not really nutraceuticals, what I've just described. They're more medications.
Yeah.
In terms of nutraceuticals, one of the unfortunate aspects of the industry is that we have a lot of nutraceuticals, but very little data in terms of their beneficial effects in any condition. So these companies bring the nutraceuticals to market, and a lot of them rely solely on sort of endorsements from customers as opposed to hard scientific data. And yeah, off the top of my head, I can't think of any that have been really well clinically tested. For Parkinson's. that you sort of could even give a recommendation of just investigating. So I can't really answer that question, I'm afraid, sorry.
Yeah, if I could just add a discussion point. I see a lot of posts on different sites, all saying Dr. this and Dr. that recommends. And when you trace it back to the website, Dr. this and Dr. that are actually selling those things. And there's a big push, especially in certain English-speaking countries, which are not in the UK, to actually do anything other than take levodopa, because they don't want to get involved with the big pharma, which is seen as the baddie.
Yep.
And I can understand it in some countries because of the cost of medication. But I think it's so easy to get waylaid by trends of, say mannitol, bimannitol, or B1, and things like that. But you really can't tell the truth. We need some proper research.
Yeah, well, I've often said that if I wasn't doing what I'm doing at the moment, I'd probably go and plant orchards of Mucuna perennis throughout the tropics in areas of Africa, for example, where they can't get L-Dopa. Mucuna perennis are a legume, and they have very high levels of L-Dopa naturally. So people with Parkinson's in those areas who can't get L-Dopa can just chew on some of those beans, and they'll be having some benefits at least. And
I used that for the first year of my Parkinson's, just for interest.
Right. Well, this is where they got L-Dopa from originally. They were sort of taking these beans and just crushing them up and extracting. That's my understanding, at least.
Okay, Simon, you're off the hook for a few minutes. I'd like to welcome Dr. Laurie Mischley to the panel. Simon has been calling for you on several questions. Can I invite Sue and Jane to rewind and put some of the questions that were put to one side by Simon in the nicest possible way?
Been asked for the top 3 things that people should know about nutraceuticals and Parkinson's. And you can extend that even to diet and Parkinson's if you wish.
Okay, totally different topics, but just say nutraceuticals from the get-go. I mean, what should I take and what should I know are 2 different things. I think the most important thing to know is just because the label says it has X in it does not mean that it has X in it. It is a wildly unregulated industry. And there are some consumer report type studies out there that say 50% of what is bought over the counter in the United States does not have in it what the bottle says it has in it. Mm. So when somebody reports to me that they're taking vitamin D or that they're taking ginkgo or glutathione, I actually don't know what they're taking, and they don't know what they're taking. So probably the first thing to know. Second thing to know is that I think there is a tremendous amount of preliminary data in Petri dishes and test tubes and rodent models suggesting at least 20 of these nutraceuticals is biologically plausible and has preliminary evidence of efficacy. So we should be excited about this entire bucket of potential therapeutics that hasn't even been tapped. Like, you know, if you think about, do pharmaceuticals work for Parkinson's? Well, which pharmaceutical for which symptoms? You know, do nutraceuticals work for Parkinson's? Well, which nutraceuticals for which goals, right? So we haven't even begun to explore all that's out there. And the presentation we just did, the poster we presented at Movement Disorder Society showed 13 supplements that were, when we surveyed probably about 50 supplements, we said, which of these have you been taking consistently over the last 6 months? 10, 12 of them popped up as statistically significantly associated with people doing better, reporting fewer symptoms over time. So I'm excited about studying nutraceuticals as a therapeutic strategy.
But
top ones, the ones I'm most excited about: glutathione, fish oil, coenzyme Q10, low-dose lithium, maybe curcumin, maybe vitamin D, B12, keeping homocysteine levels low. Those are really, really important targets, nutraceuticals wise.
I know I'm a member of the panel here, but am I allowed to ask questions as well?
Of course you are.
Okay, cool.
You don't have to
Um,
write them down either.
No, just on the topic of fish oil, because Laurie, I think an important point to make is that a lot of the products on the market, when they say fish oil, it's basically oxidized stuff, and you have to be careful as to which particular fish oil you go for, correct?
Yep. Yeah. I mean, and they have contaminants. I think there was a study here in California that said 8 out of 10 fish oils tested had higher levels than recommended of cadmium, lead, mercury, or PCBs. Right. So, not only should you take your fish oil, but it should be from not overfished regions, using small oily fish, using companies that have these standards in place. We call them pharmaceutical grade, but there is an entire group of supplements out there that are produced according to pharmaceutical grade standards. Each batch is tested by a third party for purity and potency. You're going to pay an extra $2 or $3 for each bottle, but it's kind of worth it to get the quality assurance that you're getting what you're getting. And so learning which companies those are in your region that you have access to is important.
Just coming back to the idea that nutrition is all about the quality of what you put into your body as opposed to the quantity.
Right. So tying that into food, what I was working on, I'm doing a presentation this weekend, but when I went into my study, I assumed all green beans would be good. My assumption was fresh would be better than frozen would be better than canned, but all vegetables would be good. And I'd say the biggest surprise of our research is that canned fruits and vegetables are actually associated with statistically worse progression over time. Like you're better off to eat no green beans than canned green beans. There might actually be something harmful in the lining in the can, in the way it's preserved, but it's showing up very consistently in our data that canned fruits and canned vegetables, and it's starting to look like maybe canned beans and canned fish and canned water. And so, the quality matters, the delivery system matters, and fresh is best is the dietary take home.
Laurie, I'm going to take over the questions here, but we had a question before on red meat, and I said I wish Laurie was here because I'm going to give you a terrible answer, but Laurie will give you a good answer. So
that's an easy one. There are a handful of studies that have been done that looked at who gets Parkinson's over time. They pretty consistently show the more dairy and meat you eat, the more likely you are to get diagnosed with Parkinson's. Our study looks at people from diagnosis forward, very clearly says that people who eat dairy and beef and pork are associated with worse outcomes over time. And it seems to be pretty dose dependent. The problem that we have is that almost everybody who eats pork eats beef, and almost everybody who eats beef eats pork. And so we can't tell which of those are they both a problem? Is one a problem and the other's just statistically along for the ride? But yeah.
Laurie, sorry, hang on. I'm still in charge of the questions here. Laurie, I'm going to suggest to the PenPreg organizers that they have you back to do a presentation on all of this, but just for the sake of the few minutes that we have, what should people be eating and what shouldn't people be eating? I've sort of mentioned this in my video, but coming from you would be a lot stronger, I think.
It's pretty simple. In a dose response fashion, the more fresh fruit, fresh vegetables, nuts and seeds, non-fried fish, olive oil, coconut oil, green tea, water, wine, fresh herbs and spices, brown rice, quinoa, farro, these ancient grains seem to be pretty good. And eggs are looking like they're maybe on the good list, somewhere between neutral and a little bit good, right? Like if that is most of what you eat, that's it. I mean, it's a little Mediterranean-like, it's a little mind-like, it's a plant foods, vegan plus fish. The foods that are associated with faster Parkinson's progression over time. Canned fruits, canned vegetables, dairy, beef, pork, fried foods, soda, artificial sweeteners, artificial colors and flavors. we probably all know we shouldn't be eating too much of that stuff anyway. Like this isn't nothing I'm saying should be really revolutionary. I mean, I joke that I got 2 doctorates and I learned we should go to bed early, we should drink water, we should eat vegetables, we should have friends, and you should exercise.
Sue had her hand up. I'm going to let her ask a question now.
Yeah, bearing in mind you've got that accent, Laurie, could you tell me if the studies have been done on US beef and pork or on UK or international? Because they are different in the way that they're raised.
Absolutely. So the survey is open to people everywhere in the world, but 80% of the people who have filled out the survey are in the United States and Canada. And because enough of the other folks around the world haven't filled out the survey, we don't have the power to be able to ask that question differently. You could all help with that by enrolling in the study and giving us more of that data. There are no shortage of people who kind of go kicking and screaming, looking for the loopholes, right? Like, but my yogurt is from grass-fed cows that are pesticide free and they're grown with love on my neighbor's farm, right? Like everyone has someone paged me to ask, what about camel yogurt? Like, I don't know. I mean, I have friends who smoke their, roll your own tobacco cigarettes and they try to tell me it doesn't cause cancer because the studies have never been done on the roll your own organic tobacco cigarettes. So therefore, their tobacco probably doesn't cause lung cancer the same way. I mean, you can wait until that study is done to see if your organic chicken or your UK chicken is somehow better than American chicken. And it might be because turkey is not coming up as bad. We're asking about turkey and turkey isn't on the bad list. It could be because we do fried chicken and fried, the way chicken nuggets. It could have something to do with the preparation. The large scale chicken farms and the way it's farmed might be different than what you get with turkeys. We know, and fish, seafood seems to be very good. Beans, I don't think I neglected those on the good list, but legumes are associated with better outcomes over time.
Could I put a question using a comment from Simon in the video, which you may have noticed to one of the questions, where Simon was really pretty downbeat about the possibility of big pharma funding into studies of dietary additives. I hope I'm not misquoting you, Simon. What's your view, Laurie? Do you see scope for large-scale trials on dietary additives, or are we where we are for the duration?
I do not see a day anytime in the near future where big pharma funds a dietary intervention trial. It doesn't make sense. There's no return on investment for them, right? And I don't see a day where the broccoli farmers and carrot farmers and farro farmers all bond together to fund their own trial, right? So it's going to fall onto government organizations and nonprofits, and the price tag for dietary modification trials is huge. And at the end of the day, you're not just studying the food, you're changing behavior, right? You're changing someone's ability to teach, you're changing, and like some of these studies, they deliver a gallon of olive oil every week to your doorstep, right? So they're funding food finances are a barrier to eating healthy. So, some people, it's not that the food didn't work, it's they couldn't afford all the olive oil and fresh vegetables that they were assigned in arm number 1. And so, if you want to answer, does the diet work? You have to pay for the food. If you want to answer, can people do it? Is it realistic? Then you just tell them what they should do, try and teach them and see, is it possible? And those are all different studies with different price tags and different answers.
Laurie, just on this topic of clinical trials with diet and food, they're extremely difficult clinical trials to conduct because everybody has, like we were just saying before with regards to sugar, I have a very sweet tooth and I've got absolutely no self-control. But what is a fun way, because we have to make the clinical trial fun for individuals if they're going to take part in part in one of these things. What's a fun way that you can look at the potential for food or diet to influence progression in Parkinson's? What would a clinical trial look like?
So I think it would be heavily reliant on education. I would love something maybe internet-based where people were randomized to either learning to do a MIND diet, a Mediterranean diet, a Parkinson-specific diet, or maybe a heart-healthy control sort of thing. And so you have 100 people in each arm who are all taught a set of principles, rules, given food, sample diets, sort of thing, and tracking outcomes over time. I mean, that's an effectiveness study. Like in a real world, can we implement change? And we'd mostly be comparing people to their follow-up versus their baseline, right? Because when you start feeling better, you start exercising more, you start going out more. If you're not constipated all the time, you sleep better, you're friendlier, you have more energy. I mean, you can't control away for exercise. Like these things all go together. You have to look at does changing their behavior change their symptoms? The meds start working better. A plant-based diet, it takes half as long for plant foods to move through you than animal products. I mean, just switching to a plant-based diet makes your levodopa work better because you're not constipated and you're not competing for protein, and the meds start working better. So I actually don't think it would be that hard to do, but it would have to be more focused on effectiveness and education and non-motor symptoms. We're not going to see huge improvements in tremor. We're spoiled with dopamine therapies and immediate gratification with our outcomes, but really we're going to see improvement in constipation and fatigue and pain and muscle pain, that kind of stuff. So non-motor symptoms scale, PRO-PD, that kind of stuff.
Which is really to do with quality of life, which must have a bearing on the perception of progression. I mean, if you're doing all these bad things, as one anonymous attendee commented, going to McDonald's, then for your meat, then it's your problem. You are creating the problem by going to McDonald's and having that kind of diet.
And that's a tough pill to swallow. I mean, you want to both tell people, hey, you can change your life and empower yourself to feel better without saying, your crappy diet got you here. Right? Like you want to not have them feel blame. Like, you mean I caused this myself? I mean, the answer is probably some of those milkshakes you had as a teenager may have. But we didn't know, and here we are. And so now that what can we do from this point forward?
I should add that I've got no self-control when it comes to McDonald's either.
Here's my trick in clinic. I mean, even though my goal is long-term, I mean, I'm a big fan of informed decision-making. And so even though my goal is to get somebody to high quality of life on their 100th birthday, people feel better when they start eating better. And what I will do in clinic to kind of trick people into a healthier diet is I say, give me 2 months. All I'm asking for is informed decision-making. You know how you feel when you do what you're currently doing. Do what I'm asking you to do for 2 months strict. And at the end of the 2 months, if you don't feel better, if you don't like how you feel, go back. And I'd say 95% of people stay on some newer version of their diet. I mean, they feel better. People call and they say, this is the first time in 20 years I've had 2 well-formed bowel movements a day. You don't know until you try it. I was just reading a study that, so many people's immediate knee-jerk response is, where will I get my protein? And there's just a study I was reading this morning was done in Greece, where the average person with Parkinson's and their spouse are eating 50% more protein than is recommended, right? Like you guys are doing way too much. And for every incremental increase in protein was raised your levodopa requirements. You don't realize that half of the meds that you're on might be because you're eating such a high protein diet. I mean, it is what it is. If that's the way you want to do it, you can do it that way. But a lot of people feel better by dialing back some of the protein and dialing back some of their meds and having the meds they're on work better.
Well, I'd like to ask both Simon and Laurie to comment on the general proposition that to be of practical use to us, a study of this sort needs to tell us what these things are called and who we can buy them from at the end of the day. So, because there's no point in learning that if you have 3 bits of that and 4 bits of the other, but you don't know where to buy it, it's no bloody good. So, and yet, on the other hand, that is a commercialization from a clinician and a medical industry point of view. So how do you square that for us in the future? Simon.
Well, this is where my internet connection cuts out.
Well, I would say for clinical trials, I mean, there is a whole level of quality control. Before you invest in a study, you want to make sure that this product you're studying has X, Y, and Z. But glutathione, for instance, you know, where our data says even people taking over-the-counter $20 a month junk, we're still seeing a signal. Those people are still reporting fewer symptoms over time. So model and somehow tweaking it in a way that they can own it, or packaging it in a way that nobody else can infringe on that. And yeah, it's industry's inability to profit off of some of this stuff that is a barrier to us moving research forward. Industry, and there are people, I never thought the ketogenic diet would be profitable. And now there are apps, right, where you can spend $5, get an app and learn how to eat ketogenic. And so there are ways for industry, I think, to get involved in packaging and delivering diet and lifestyle and nutraceuticals. It's just we're not the current system.
Thank you, Laurie. Simon, I'm going to give you the last word.
The last word? My wife never gives me the last word. This is a very unique situation. There are investigator-led trials that are looking at some of these things. Like there is the NOPARK study being conducted in Norway at the moment, which is looking at a nutraceutical called Nicotamine Riboside. And it's a very large study. It's a phase 2 study, but it's involving 400 people being treated for 12 months with Nicotamine Riboside. And there are investigator-led situations, but they are very difficult to fund. It requires government funding or charitable funding to get those things off the ground. And as Laurie says, the business model just isn't there. There's no intellectual property, so there's no profit at the end of the day in a lot of these cases. But that's where organizations like Cure Parkinson's, Michael J. Fox, and etc., Parkinson's UK could be stepping in and supporting some of that stuff, because this is immediately applicable aspects of life for people with Parkinson's, as opposed to waiting for 10 years down the line when a phase 3 clinical trial finally says yes or no, and the regulator says, give us 12 months to think about it. It would be this particular aspect of your diet could be changed tomorrow. Have a try.
Thank you, Simon. Thank you, Laurie. Thank you for your time, all of you. And as they say, we will be back.